Hi, I'd like to welcome Dr. Richard Libman again. He's the Vice Chair of Neurology at LIJ Medical Center, Chief of Vascular Neurology, and a Professor of Neurology at the Zucker School of Medicine at Hofstra, Northwell. And hello again, Dr. Libman. I understand that there is some exciting news about the treatment of large strokes with a large blood clot that you're having a lot of success with.
Nice to see you again, Ginny, and thank you again for having me. Um, the question about large strokes, it seems like something so obvious. Well, if we can treat small strokes, if we can treat medium-sized strokes, why can't we treat large strokes? And so just to clarify, what we're talking specifically about here is what's called the endovascular approach to stroke treatment, which is when we go in with a catheter, usually through the groin, feeding it all the way up, usually up through the neck, through the carotid artery, right up into the head, and then mechanically pulling out a clot. So it seems so simple. It's almost like a roto-rooter, almost what a plumber would do with a blocked pipe. It seems so simple, although of course it is a very delicate procedure and requires a lot of skill and a lot of very, very fine kind of instruments and catheters and devices to actually pull these clots out. So that's the background. And in the last few years, putting aside the question of large strokes for a minute, just to remind everyone that this technique of putting in a catheter and mechanically pulling out a clot has proven to be not only effective for stroke treatment, but actually one of the most effective treatments for any condition in all of medicine, including outside of stroke, outside of neurology, including any treatment for infectious diseases, for infections, for heart attacks, for cancer, for anything, you name it. This technique of pulling out blood clots, as simple as it sounds, of course it has risks, has been proven over and over again now in multiple studies to be one of the most powerful and robust treatments in all of medicine. That's number one. Number two, the time window for this kind of treatment is up to 24 hours. So very different from giving the IV clot busting treatment such as tenecteplase, which still has a 4.5 hour window. When a major blood vessel inside the head is blocked, this catheter-based technique, so-called mechanical clot retrieval, can be used up to 24 hours. Now, just to qualify, as we always do in stroke treatment, just because you have a certain amount of time doesn't mean you have to wait that amount of time. We know very well from now years and years of study, whether it's with intravenous treatment with a clot buster or whether it's with this catheter-based mechanical clot retrieval, you may have 24 hours. If you get to the hospital faster, you can be treated earlier, and the treatment is almost always more effective when you treat earlier than when you treat later. Having said that, yes, we have up to 24 hours to treat people who have come in with stroke with occlusion or blockage of a major vessel inside the head. Now, what's new about this? Well, it was always thought that if you come in, doesn't really matter when, let's say 6 hours, 8 hours, 12 hours, or anywhere up to 24 hours. If you already have a very large stroke, meaning there's a large amount of brain that's damaged, well, how can we possibly help that person? Because there's so much brain that's already damaged. And then the other thing is, we have tests that can show us on a CAT scan right away when you come in with your stroke, what size of the stroke is irreversible. That means that part of the brain is dead. And then what part of the brain, how much around it is maybe deprived of blood or starving for blood, but is still salvageable. In other words, it's still alive. That part of the brain may be stunned. It may not be working very well. And that's why you come in and let's say you're completely paralyzed or cannot speak. But these tests can show us what's the size of the stroke that's irreversible, and how much around it not functioning well because of lack of blood flow, but can be saved if we can reestablish blood flow ASAP. That's what we've been doing for quite a few years now for all kinds of strokes, but for the most part, smaller strokes or medium-sized strokes, but not the huge strokes. Why? Because when the studies were done that looked at this mechanical clot retrieval, everybody thought there's no way we can help patients with humongous strokes. What is the point? And as a result, patients who came in with these large strokes were automatically excluded from these major research studies because everybody thought it's completely pointless. We'll probably end up just hurting them. Not only would we not be able to help them because the stroke is so large, we'll probably end up hurting them because you can get complications, maybe will cause bleeding. There's just so much damage done already. It's pointless. Well, that was kind of the philosophy for the first few years, meaning over the past few years. And then over the last year to a year and a half, everybody said, and some sort of investigators and scientists and doctors said, maybe this doesn't really make sense that we're automatically excluding these people with such large strokes. We better test it before we go to the end of time, basically saying, well, we never tested it, but we just assume we're not going to be able to help people with very large strokes. That doesn't seem fair because that is excluding people from treatment, patients from treatment, who have the worst and most devastating strokes. As a result, there have been 2 large studies specifically geared towards patients with very large strokes, and you can measure how big it is. You can see it on a CAT scan, however you measure it, CAT scan, MRI. And these 2 large studies were devoted exclusively to patients with very large strokes. So if you had a very small stroke, sort of an average size stroke, you didn't even get into the study. We already know we can help you if you have a small or medium-sized stroke. So here were 2 larger trials, larger studies devoted exclusively to patients with very large strokes. And it was basically divided into 2 arms, as all these studies are, flip of a coin, randomized trial. Some patients got catheter-based treatment, mechanical clot retrieval, and some people got best medical therapy. And that best medical therapy could include intravenous clot-busting drugs like tenecteplase or TPA, plus anything else that we think is the best thing to do, but everything except using the catheter. So that was the comparison, and that's a randomized trial. And lo and behold, both studies were positive, showing that even when you say, well, there seems to be so much brain that's damaged already, what could be the point of trying to open up a blood vessel when there's so much damaged brain? Lo and behold, we weren't as smart as we thought we were, because people are telling us and our patients are telling us, yes, you can still help us. And sure enough, these 2 studies were positive, showing that even when you come in within 24 hours, it's the same time window as we do for sort of the standard size strokes and average strokes. If you come in within 24 hours, again, the earlier, the better, but we have within 24 hours, looks like a big stroke, treat it. Go in with the catheter, pull out the clot, restore the blood flow, and patients do better. Now, do you say, well, are all these patients miraculously sort of jumping off the table and jumping out of bed and starting to dance? The answer is no, because it's a bad stroke and the stroke is already very large. Overall, these patients don't have the best outcome. But what the studies have shown us, that even though overall in the whole population, treated or untreated, a lot of them are not doing so well, but we can still greatly increase the number of patients who do well if they're treated than if they're not treated. Meaning we can't save every patient, but if we treat you, you still have a much better chance of getting better than if you're not treated, even with all of this pre-existing damage to your brain. And basically, it surprised everyone. And it's really amazing. And it's kind of opened up, a world of treatment to patients who otherwise would not have been treated. And at least a proportion of those patients who come in with really large strokes, devastating neurological problems with paralysis and loss of speech, etc., a fair number of those patients are doing remarkably well, going home, sometimes not even needing rehab, actually, just going home, and others going to rehab, whereas in the past, they would have either gone to a nursing home or died. And that's the long and the short of it. It's basically making us work harder to treat more patients, and that's our job, and that's what we do. And so that's really the new horizon that basically that we've reached in treating stroke patients with very large strokes.
I have a question, Dr. Libman. So if you have a large clot, it kills off, we know it's going to kill off a certain amount of brain cells. But is there like more of, a gray area where maybe some of that can come back if the blood flow is returned to it fast enough?
That's exactly right, Ginny. You know, it's hard to know how are we helping these patients if they have such huge strokes. And the traditional thinking about stroke is that all of this brain is basically dead. It's basically irreversibly damaged. How can we be helping these patients? Well, there are two possibilities. One is that what you're calling that gray area is the area just around the stroke, just around it, with areas of brain that are not getting enough blood. But if you can reestablish the blood supply, that area of the brain stays alive. Whereas if you don't reestablish the blood supply, that area of brain that's still alive but not functioning well can go on and become part of the stroke, at which point it's irreversible and it's dead brain. So one possibility is just we are salvaging or saving that area around the basic stroke, the core stroke, and that's allowing people to recover better or more effectively. And the other possibility is that even within that core of stroke damaged brain that we think is irreversible and dead, well, it may be that with our technology and our ideas, we're not exactly correct. And that even within that area of what we think is completely gone, there may be areas of brain, in fact, that are still functioning, that are salvageable, but we can't see them. But when we reestablish the blood flow, those areas that are kind of weakened and stunned by the lack of blood supply within the core stroke can kind of revive and jump up and start doing the dance that they always wanted to do since they were in high school, but we're told that they really can't dance, so don't even try. But we're showing that those brain cells can find that youthful spirit and come back as long as we can reestablish the blood flow.
It's amazing news, and thank you. And I'm sure that that's going to give a lot of people who have stroke in their family, or their lifestyle, or maybe they've had a small stroke and they might be looking at a larger stroke. It will give them more hope that something, it's I don't want to use this word death sentence, but it's not the end of everything.
100%. So it's a reminder, doesn't matter how mild or how severe, if you detect the signs of stroke, sudden weakness on one side, sudden paralysis, sudden numbness, sudden loss of speech, twisted smile, any of those signs, call 911, get to the emergency department. Doesn't matter what else is going on. If you get there quickly enough, small, medium, or large stroke, you can be treated.
Thank you so much, Doug. Thank you so much. And we'll chat again about another topic in a few minutes. Thank you.
Very good.